I'm Shingo Kato from Yokohama City University. I'll talk about the multicenter study of cardiac MRI for patients with non-ischemic dilated cardiomyopathy in Japan, image heart failure registry. This is my disclosure information. Mid-wall fibrosis on rate gadolinium-enhanced MRI is a significant predictor of adverse events in patients with non-ischemic dilated cardiomyopathy. A prior meta-analysis has shown that the hazard ratio for sudden cardiac death was 4.3. In the guideline of Japanese Circulation Society, LG is recommended as Class 2A for risk stratification. Still, the evidence level remains C. This is probably due to the lack of large-scale clinical studies and meta-analysis for the Japanese population. Recently, heart failure with mild reduced EF was introduced, and some studies showed a difference in prognosis against HFrEF. So far, no prognostic data of CMR is present for mild reduced EF. The purpose of this prospective multicenter study is to evaluate the clinical utility of CMR for Japanese patients with NIDCM. Patients were enrolled from 6 institutions. Inclusion criteria include heart failure patients with LVEF less than 50% and absence of significant coronary stenosis with angiography or computed tomography. We excluded HCM, sarcoidosis, amyloidosis, severe valvular disease, ARVC, LV non-compaction, and severe renal dysfunction. From Cine MRI, we measured LV and RV volumes. On LG MRI, the presence and volume of LG were calculated. Extracellular volume fraction was assessed by T1 mapping. We calculated myocardial strain using feature tracking method. Primary endpoint was cardiac death. Secondary endpoint was all-cause death, heart failure hospitalization, ventricular tachyarrhythmia, ICD or CRTD implantation, and cerebral infarction. Follow-up information will be obtained using electronic medical record. Let me show you the results. This slide shows the patient characteristics. The mean age was 61-year-old and 77% were male. The prevalence of NIHA 3 or 4 was higher in patients with HFrEF compared to mildly reduced EF. In addition, BNP was more elevated in patients with HFrEF than mildly reduced EF. The prescription rate of beta blocker, ACE-ARB, MRA was higher in HFrEF than mildly reduced EF. This slide summarizes the MRI parameters. Mean LVEF was 31% and 49% had LG on LV myocardium. HFrEF had significantly lower LVEF and RVEF. The presence of LG was higher in HFrEF than mildly reduced EF. The strain of 3 direction was more impaired in HFrEF than mildly reduced EF. To the best of our knowledge, this study is the first prospective multicenter study in Asian countries. At this time, we cannot show the prognostic data because we do not have outcome data yet. We will continue to follow up. This study can provide the prognostic value of CMR, not only for HFrEF, but also for mildly reduced EF. We expect CMR parameters such as T1 mapping and strain to be useful for risk stratification. In conclusion, clinical evidence of CMR is not sufficient for Japanese patients with NIDCM. This may interfere widespread clinical use of CMR. We believe the result of this study will contribute to making rigorous evidence of CMR for Japanese patients with NIDCM. Thank you so much for your kind attention.
The title is Trends and Predictors of Non-Cardiac Death in Acute Myocardial Infarction. Insights from the Tokyo Tissue Network Multicenter Registry between 2010 to 2019. I have nothing to disclose for this study and the other authors as well. Introduction. Patients with acute myocardial infarction commonly have multiple comorbidities, and some of these patients die in the hospital from causes other than cardiac complication. Limited information is available on the mode of death in patients with AMI. The aim of the study was to determine the incidence, clinical characteristics, and predictors of in-hospital non-cardiac death in patients with AMI using Tokyo Tissue Network Registry. In method, Tokyo Tissue Network Registry included 38,000 consecutive patients with AMI admitted to CCU in the last decade. The primary endpoint of the present study was in-hospital non-cardiac death. The statistical methods were quite general. There were total 2,700 in-hospital deaths, and the proportion of non-cardiac deaths was 15.6%. Here you can see the primary diseases responsible for non-cardiac deaths. Almost half of them were infection, and the next was bleeding and respiratory failure, cerebral infarction, and so on. So here you can see the baseline characteristics among survivor and cardiac death and non-cardiac death. So please see the p-value between the cardiac death versus non-cardiac death. Body mass index was lower in non-cardiac death compared with cardiac death. And smoking rate was higher in non-cardiac death. Vital signs such as blood pressure, respiratory rate, and body temperature were different between the two groups, and CPA on arrival, higher clip class, and cardiogenic shock were more frequent in cardiac death group, and very interestingly, AMI onset in hospital was more frequent in non-cardiac death group. And hemoglobin was lower in non-cardiac death group, and peak CK was higher in cardiac death group, and CRP was higher in non-cardiac death group. Mechanical support such as IVP or ECMO were more frequent in cardiac death group, and the length of hospital day was much longer in non-cardiac death group. Here you can see the multivariate predictors for non-cardiac death: higher age, lower BMI, and AMI onset in hospital, higher clip class, lower hemoglobin level, and non-PCI. So this is the multivariate predictors for cardiac death group. So finally, BMI and AMI onset in hospital were specific predictors for non-cardiac death. Here you can see the annual change of in-hospital non-cardiac death. The incidence of non-cardiac death didn't change in the last decade. In conclusion, the incidence of non-cardiac death was significant in patients hospitalized for AMI. Thus, the prevention and management of non-cardiac complications might be vital to reduce acute phase mortality in patients with AMI, especially those with predictors of in-hospital non-cardiac death. Thank you for your kind attention.